Atherosclerotic cardiovascular disease, largely heart attacks and strokes, is the leading cause of death globally. Hypertension or increased blood pressure is an important risk factor for that. And there was disagreement up until this study, and maybe even continuing afterwards, what the optimal or kind of ideal target blood pressure we should be shooting for to substantially or sufficiently reduce risk associated with increased blood pressure and cardiovascular disease. I think, although this was a lot of older subjects, this may be interpreted as support, again, not direct kind of evidence for, since it was in this population, but support that younger individuals should be shooting for below 120 millimeters of mercury, and that they shouldn't just be okay with their blood pressure being, above 120 systolic or above 130. Even though there were improved outcomes, this may not necessarily be as simple as the study kind of suggests. Hey everybody, welcome to post number 2 of the Talking Studies series, a series where I break down interesting research papers that I've read and share some cool findings that I've come across. In this episode, I'm going to break down the SPRINT trial, which is a fairly well-known paper that was published in 2015 on the effects of intensive blood pressure lowering versus the kind of standard blood pressure lowering. It's titled A Randomized Trial of Intensive versus Standard Blood Pressure Control, published in the New England Journal of Medicine. And it's important for a few reasons. First, in general, why is blood pressure important? Atherosclerotic cardiovascular disease, largely heart attacks and strokes, is the leading cause of death globally. And research suggests that blood pressure is a pertinent risk factor for cardiovascular disease. In particular, I read a paper recently called Low-Density Lipoproteins Cause Atherosclerotic Cardiovascular Disease, Pathophysiological, Genetic, and Therapeutic Insights, a consensus statement from the European Atherosclerosis Society Consensus Panel. And that was a really great review breaking down kind of mechanistic explanations of how LDL particles can lead to atherosclerosis, particularly when they move from the inside of your blood vessels into the blood vessel wall or the endothelium. And I'll put up one of the graphics they shared where they show a bunch of different factors that are related to this process, and hypertension is listed as one of them, which is a little bit intuitive in that if you just consider the stress of increased pressure on your blood vessels over time from pumping blood, pretty much every second or so that you're alive over decades is going to lead to issues, particularly if it's elevated. And it can cause damage to that endothelial wall, which is pertinent for what I just described, where damage to that wall can lead to increased passage of LDL particles into the endothelium, which, if they are retained, can lead to a bunch of steps and processes that come together to become atherosclerosis, or kind of buildup of that fatty plaque in your wall that can eventually lead to things like heart attacks and strokes. So that's why blood pressure is important, because it is a very pertinent risk factor over a lifetime for the leading cause of death globally. Starting off in the study, quote, clinical trials have shown that treatment of hypertension reduces the risk of cardiovascular disease outcomes, including incident stroke by 35 to 40%, myocardial infarction, which is heart attack, by 15 to 25%, and heart failure by up to 64%, end quote. And the reason this particular study on blood pressure is kind of well known or discussed is that up until this time, there was some debate about the ideal blood pressure to be targeting and whether any given target was low enough or optimal for reducing risk. And so the researchers kind of designed the trial to test whether or not lowering blood pressure to below 120 milligrams per mercury, particularly systolic blood pressure. They go in the study and kind of describe how systolic blood pressure is more important than diastolic blood pressure when it comes to predicting risk. And so they looked at less than 120 milligrams per mercury, or millimeters per mercury, compared to less than 140 millimeters per mercury. Quote, however, the target for systolic blood pressure lowering is uncertain. Observational studies have shown a progressive increase in cardiovascular risk as systolic blood pressure rises above 115 millimeters of mercury. but the available evidence from randomized controlled trials in the general population of patients with hypertension only documents the benefit of treatment to achieve a systolic blood pressure target of less than 150 millimeters of mercury, with limited data concerning lower blood pressure targets." End quote. So here is kind of the controversy, or the question at hand, is whether or not lower is better, particularly beyond this 150 millimeters per mercury or 140 millimeters per mercury. I believe at the time of the study, the sort of standard of care was to get people with hypertension to below 140 millimeters per mercury. And I'm not sure exactly what the standard is today, but I believe there's a movement, now this is 9 years later, to lower the standards where anything over 120 is considered more dangerous or putting people at higher risk than maybe it was viewed at the time of this study, likely because of research like this SPRINT trial. And so for the design of the trial, quote, "SPRINT was a randomized, controlled, open-label trial that was conducted at 102 clinical sites organized into 5 clinical center networks in the United States, including Puerto Rico," end quote. So it was a pretty big trial involving a bunch of different physicians. And like I said, there are 102 different clinical sites spread out throughout the United States and Puerto Rico. Quote, "Participants were required to meet all of the following criteria: an age of at least 50 years, a systolic blood pressure of 130 to 180 millimeters per mercury, and increased risk of cardiovascular events." Increased cardiovascular risk was defined by one or more of the following: clinical or subclinical cardiovascular disease other than stroke, chronic kidney disease excluding polycystic kidney disease with an estimated glomerular filtration rate of 20 to less than 60 milliliters per minute per 1.73 meters squared of body surface area. Pretty much just a measurement of how well your kidneys filter your blood, which is related to blood pressure, because your blood pressure impacts how much blood is being forced into the blood vessels around the kidneys that feed that blood through there to get filtered. Calculated with the use of the 4-variable modification of diet and renal disease equation, a 10-year risk of cardiovascular disease of 15% or greater on the basis of the Framingham risk score. So this is pretty much your risk of a cardiovascular event over 10 years. Or an age of 75 years or older. Patients with diabetes mellitus or prior stroke were excluded, end quote. And moving on a little bit more, quote, "Eligible participants were assigned to a systolic blood pressure target of either less than 140 millimeters per mercury, the standard treatment group, or less than 120 millimeters per mercury, the intensive treatment group. Randomization was stratified according to clinical site. Participants and study personnel were aware of the study group assignments, but outcome adjudicators were not," end quote. So looking particularly at the inclusion criteria, it's interesting to note that they intentionally selected individuals that were at higher risk of having a cardiovascular related event. This is commonly done, based on what I've read, to increase the likelihood of finding an effect. Because with something like with cardiovascular disease that develops over time, if there aren't enough events, it's difficult to see any difference that might be made across 5 years in a randomized controlled trial. And it's difficult to run a randomized controlled trial for, say, 20 years, where you would see the benefit in people who are at lower risk, maybe, in where there weren't as many events. So that's why they select people who are at higher risk. So there's a higher chance of there being events anyways. And therefore, there's a greater likelihood that a reduction in events due to the intervention will be statistically noticeable. And another notable thing I found when looking at the methods and design is that the physicians at each site had leeway of how to, which medications to use to lower the blood pressure of these patients. So just like your doctor would use kind of context of you and your medical history and things like that to select which medications they would put you on for your blood pressure, they would do this for the different patients. So there weren't particular medication requirements, although some medications were suggested, but the physicians could add in their own medications based on their own sort of medical opinion. Quote, "All major classes of antihypertensive agents were included in the formulary and were provided at no cost to the participants. SPRINT investigators could also prescribe other antihypertensive medications not provided by the study. The protocol encouraged but did not mandate the use of drug classes with the strongest evidence for a reduction in cardiovascular outcomes, end quote. Continuing on in the study, quote, participants were seen monthly for the first 3 months and every 3 months thereafter. Medications for participants in the intensive treatment group were adjusted on a monthly basis to target a systolic blood pressure of less than 120 millimeters mercury. For participants in the standard treatment group, participant medications were adjusted to target a systolic blood pressure of 135 to 139 millimeters mercury. And the dose was reduced if systolic blood pressure was less than 130 millimeters mercury on a single visit or less than 135 millimeters mercury on 2 consecutive visits. Dose adjustment was based on a mean of 3 blood pressure measurements at an office visit while the patient was seated and after 5 minutes of quiet rest. The measurements were made with the use of an automated measurement system, the Model 907 Omron Healthcare. Lifestyle modification was encouraged as part of the management strategy. So notably there, they had guidelines and protocols in place to assure that the patients were staying within the blood pressure range that they wanted. So in the standard group in particular, they were trying to get the patients below 140 millimeters mercury, but they were making sure that if they dropped below 135, that they would change the medications they were giving them to make sure that they didn't continue dropping, and so that they would maintain a difference between the intensive group and just the standard treatment group. Moving on to some of the outcomes that they actually looked at. Quote, the primary hypothesis was that treatment to reach a systolic blood pressure target of less than 120 millimeters of mercury, as compared with a target of less than 140 millimeters mercury, would result in the lower rate of the composite outcome of myocardial infarction, acute coronary syndrome not resulting in myocardial infarction, stroke, acute decompensated heart failure, or death from cardiovascular causes. So this composite outcome is a combination of all of those outcomes that I just listed. Secondary outcomes included the individual components of the primary composite outcome, death from any cause, and the composite of the primary outcome or death from any cause, end quote. Moving down a little further, quote, we also assessed renal outcomes using a different definition for patients with chronic kidney disease at baseline and those without it. The renal outcome in participants with chronic kidney disease at baseline was a composite of a decrease in the glomerular filtration rate of 50% or more, confirmed by a subsequent laboratory test, or the development of ESRD requiring long-term dialysis or kidney transplantation. In participants without chronic kidney disease at baseline, the renal outcome was defined by a decrease in the glomerular filtration rate of 30% or more to a value of less than 60 milliliters per minute per 1.73 meters squared incident albuminuria. So this is albumin, a protein that could be found in your urine, or increased levels could be found in your urine if your kidneys are dysfunctional, defined for all study participants by a doubling of the ratio of urinary albumin in milligrams to creatinine in grams. From less than 10 at baseline to greater than 10 during follow-up was also a pre-specified renal outcome, end quote. Moving on to some of the serious adverse events that they looked at. Adverse events are essentially negative side effects of the intervention. Quote, serious adverse events were defined as events that were fatal or life-threatening, that resulted in clinically significant or persistent disability, that required or prolonged a hospitalization, or that were judged by the investigator to represent a clinically significant hazard or harm to the participant that might require medical or surgical intervention to prevent one of the other events listed above. A short list of monitored conditions were reported as adverse events if they were evaluated in an emergency department: hypotension, syncope, injurious falls, electrolyte abnormalities, and bradycardia. The relationship of serious adverse events to the intervention was assessed by the trial safety officer and reviewed monthly by the safety committee, end quote. Now, that last part is important because in this study, like some other studies looking at serious medical events or death for the outcome, there will be preset limits where the study will be stopped if those limits are reached. For example, if there's a serious difference in death or cardiovascular events, they'll stop the trial for ethical reasons because it would be a hazard to the individuals in the control group, in this case in the standard treatment group, to not be put on the intervention because there is a big difference in events and death. And we'll come up to that in just a second as we start to address what the study actually found. So they ended up including over 9,000 subjects, and they stopped the trial short due to the safety concerns that I was just talking about. Quote, a total of 9,361 participants were enrolled between November 2010 and March 2013. Descriptive baseline statistics are presented, Table 1. On August 20th, 2015, the NHLBI, which I believe is like a national health institution organization, director accepted a recommendation from the Data and Safety Monitoring Board of the trial to inform the investigators and participants of the cardiovascular outcome results after analyses of the primary outcome exceeded the monitoring boundary at 2 consecutive time points, thus initiating the process to end the blood pressure intervention early. The median follow-up on August 20th, 2015 was 3.26 years of the planned average of 5 years, end quote. So there was such a difference in outcomes between the two groups that they decided it was unethical to carry on, and they ended the trial. Notably, this occurred in just an average of 3.26 years of follow-up. I guess it's important to take into account that follow-up differs by subject. So it's not like everybody signs up and starts on day one. As they mentioned, I think it was over the course of roughly 3 years, they were enrolling subjects. So different people have different start times, but the average follow-up duration for each subject was 3.26 years, which isn't a ton of time. Like I mentioned, 5 years isn't even a ton of time for cardiovascular events to show, or for any other type of event that takes a long time to kind of come into fruition and develop. As far as I understand it, 5 years is used because, like I said, going beyond that is difficult from a practical standpoint for randomized controlled trials. But 3.26 years, as far as I understand it, is fairly short to see seriously notable outcomes. Before we get to the actual outcomes, we'll take a look at the kind of baseline characteristics and breakdown between the two different groups. Notably, the patient population is fairly diverse. And also, just like they set out to in the beginning, they did have a patient population that was fairly seriously at risk of cardiovascular disease events or death. So I'll put up the kind of table from the study. What you'll see is racially or ethnically, I think the study's pretty diverse. Although you see about 57% of the subjects are non-Hispanic white, but based on research I've read, there are a lot of circumstances where one race or one ethnic group will account for over 90 or even 95% of all of the subjects. So considering in comparison to that, based on the other research I've read, this is fairly diverse in that it's representing at least several races or ethnic groups. Of course, maybe it's not optimally, but I think that's a notable thing to bring up, especially considering that there were over 9,000 subjects. And also there's, 36% of the subjects are female. Again, not a perfect 50-50, but much better than, predominantly, 90+% male or 90+% female. Another notable thing that I want to look at is that the Framingham 10-year cardiovascular disease risk score requirement of being greater than or equal to 15%, 61.4% in the intensive treatment group and 61.2% in the standard treatment group met this requirement. So that means that over half of the subjects in each group have a greater than or equal to 15% chance of a cardiovascular disease event in the next 10 years. And if you scroll down a little further in the baseline characteristics table, you'll see that the average Framingham 10-year cardiovascular disease risk score is about 20% in each group. So the average for these subjects, the average risk or probability of having a cardiovascular disease event in the next 10 years is 20%, which is pretty notable, I think. Now, moving on to some of the actual results. Looking at the blood pressures of the different groups throughout the study. Quote, the two treatment strategies resulted in a rapid and sustained between-group difference in systolic blood pressure. At 1 year, the mean systolic blood pressure was 121.4 millimeters mercury in the intensive treatment group and 136.2 millimeters mercury in the standard treatment group, for an average difference of 14.8 millimeters mercury. The mean diastolic blood pressure at 1 year was 68.7 millimeters mercury in the intensive treatment group and 76.3 millimeters mercury in the standard treatment group. Throughout the 3.26 years of follow-up, the mean systolic blood pressure was 121.5 millimeters mercury in the intensive treatment group and 134.6 millimeters mercury in the standard treatment group. And the mean number of blood pressure medications was 2.8 and 1.8 respectively. Notably, at baseline, the average medication use was 1.8 for each group. So based on averages, the standard treatment group didn't actually increase medications used, but the intensive treatment group went up by an average of one medication. Of course, there'll be differences for different individuals, but on average, that's how it went. The relative distribution of antihypertensive medication classes used was similar in the two groups, though the use of each class was greater in the intensive treatment group, end quote. So notably, even though there weren't strict guidelines on which medications the physicians should use, the distribution of different hypertension medications used was fairly similar between the two groups, just that the intensive treatment group used more total medications, or maybe more, just like their name implies, intensive prescriptions. Now, moving on to the good stuff. Quote, a primary outcome event was confirmed in 562 participants, 243 or 1.65% per year in the intensive treatment group, and 319 or 2.19% per year in the standard treatment group. Hazard ratio with intensive treatment was 0.75, which equates to a 25% reduction in risk for the intensive treatment group. The confidence interval, or pretty much the interval with which the statistical analysis provides us 95% confidence that the true result lies in, is 0.64 to 0.89. So pretty much we're 95% confident. We don't know for sure, applying this to everybody, the real risk reduction will be 25%, but we're pretty confident based on the factors put into the statistical analysis that the true risk reduction or hazard ratio is somewhere between 0.64 and 0.89. Now that I'm done with my statistical tangent, continuing on, separation in the primary outcome between the groups was apparent at 1 year. The between-group differences were consistent across the components of the primary outcome and other pre-specified secondary outcomes, end quote. Moving on, quote, a total of 365 deaths occurred, 155 in the intensive treatment group and 210 in the standard treatment group. Hazard ratio 0.73, 95% confidence interval 0.6 to 0.9. Separation in mortality between the groups became apparent at approximately 2 years. Causes of death are provided in the supplementary tables. The relative risk of death from cardiovascular causes was 43% lower with the intensive intervention than with the standard treatment, end quote. And as I'm talking, if I haven't already, I'll throw up some graphs to show kind of a timeline of these events. If we look at them, let's see here, for the primary outcome, you'll see that they have kind of two graphs shown in the upper half of this figure. And that's because the differences were so small on an absolute standpoint that you had to zoom in to really see them. That's what you see in the smaller graph. You see that the vertical axis has much smaller increments. And if you've watched Shortcut U or listened to Shortcut U or read Shortcut U at all, you know that I think a lot about relative risk versus absolute risk. And from the looks of it here, the fact that, I read something by Peter Attia recently talking about a similar figure for another paper where the fact that you have to zoom in to see the difference kind of tells you that there's not a huge absolute difference. But we should also consider, I think, what I brought up earlier about how this was a very short-term study looking at events that usually take place over a longer duration of time. And even with the kind of short set duration of 5 years, it was only 3.26 years because they stopped the trial early. Anyways, you can see kind of in the graphs there. And then if we move on to one of the tables that shows the outcomes, you'll see that the primary outcome is statistically significant. If you look at the rightmost column, the p-values, since it's less than 0.05, it's statistically significant. And if you move down, you'll see that some of the individual outcomes that were a part of that composite, right, the different outcomes that contributed to the primary outcome, some of them aren't statistically significant. So the myocardial infarction, acute coronary syndrome, and stroke individually are not statistically significant. But when you combine those events together and look at the differences between intensive treatment and standard treatment, you do see a difference, which is the primary outcome. Notably, like I already addressed, one really big difference, at least from a relative perspective, is that there was a 43% decreased risk of death from cardiovascular disease, which I think is telling, as we'll kind of get to in the discussion, how the more aggressive lowering of blood pressure led to benefits in terms of these risks. Moving on in the paper, quote, the numbers needed to treat to prevent a primary outcome event, death from any cause, and death from cardiovascular causes during the median 3.26 years of the trial were 61, 90, and 172, respectively, end quote. This is very important to take into account, I think, especially in the context of the absolute differences or the small absolute differences that I was mentioning a minute ago, in that the number needed to treat statistic is essentially how many patients you need to treat, as I understand it, over the course of time that we're looking at to see a benefit. And so, in terms of a primary outcome event, so any of those cardiovascular disease events occurring, you need to treat 61 individuals in order to see a benefit or to prevent one of those events from occurring. And in terms of death from any cause, you need to treat 90 individuals, death from cardiovascular causes, 172. Now, I think it's kind of arbitrary, a little bit subjective about whether or not that makes a big difference, but considering maybe the prevalence of hypertension and cardiovascular disease risk in America, for example, or globally, 61 doesn't seem like a huge number to me, anyways. Now, it is important to note that although there were some improvements in these risks, there were also differences in adverse events. Quote, among participants who had chronic kidney disease at baseline, no significant between-group difference in the composite outcome of a decrease in the glomerular filtration rate of 50% or more, or the development of ESRD was noted, though the number of events was small. Among participants who did not have chronic kidney disease at baseline, the incidence of the outcome defined by a decrease in the EGFR of 30% or more to a value of less than 60 milliliters per minute per 1.73 meters per meter squared was higher in the intensive treatment group than in the standard treatment group. 1.21% per year versus 0.35% per year, hazard ratio of 3.49. Notably, this is an increased risk of 249%. I think, if I'm doing my math right. Yeah, 249%. And the 95% confidence interval is 2.44 to 5.10. So up to a 400% increase in risk, over a 400% increase in risk, end quote. Moving on with another quote, quote, serious adverse events occurred in 1,793 participants in the intensive treatment group, which is 38.3%, and in 1,736 participants in the standard treatment group, which is 37.1%. Hazard ratio with intensive treatment, 1.04. So a 4% increase in risk, which was not statistically significant. Notably, when you look at adverse events on the whole, it seems like there's not that big of a difference. However, continuing on, serious adverse events of hypotension, syncope, electrolyte abnormalities, and acute kidney injury or acute renal failure, but not injurious falls or bradycardia, occurred more frequently in the intensive treatment group than in the standard treatment group. Orthostatic hypotension, as assessed during a clinic visit, was significantly less common in the intensive treatment group, end quote. So notably, looking at adverse events as a whole, there doesn't seem to be a huge difference. However, if we look at adverse events that are particularly related to blood pressure and particularly related to these more intensive decreases in blood pressure, issues like hypotension, syncope, which is essentially passing out, electrolyte abnormalities, and acute kidney injury or acute renal failure, we do see a meaningful increase in risk of these adverse events in the intensive treatment group, which is important to consider when we're weighing the decreased risk of cardiovascular events and the increased risk of these adverse outcomes. Notably, though, if we look at absolute differences or just absolute occurrence of these adverse events, I'll show one of the tables here. There were similar percentages in each group of having overall adverse events, like I mentioned. Then if we look at the absolute risks, which going through the second and third columns, you'll see that for hypotension, for example, only 2.4% of the adverse events were hypotension, and only 1.4% were or in the intensive group, and only 1.4% in the standard treatment group. So on absolute terms, there weren't a ton of patients having these issues. And this is the same if you look at the rest of these individual adverse events. Now, moving on, it's notable that the authors hypothesized, as kind of I alluded to, that the differences in renal outcomes in particular were potentially due to aggressive use of blood pressure medications in the intensive treatment group. And this is essentially because a lot of the medications used to lower blood pressure impact the kidneys and how they filter blood. Like I was mentioning before, it impacts, or blood pressure is related to kidney function. And the medications kind of leverage the fact that kidney function impacts blood pressure as well, because the amount of liquid, water and electrolytes that your kidney is filtering out and pushing off to your bladder for you to excrete in your urine impacts the volume of the blood in your vessels. And just like in a hose, you could figure that the greater the volume in the hose, the greater the pressure, and the less volume in the hose, the lesser the pressure. The same is true of your blood vessels. Quote, among participants who had chronic kidney disease at baseline, the number of participants with a decrease in the glomerular filtration rate of 50% or more, or reaching ESRD over the course of the trial, did not differ significantly between the two intervention groups. Among participants who did not have chronic kidney disease at baseline, a decrease in the glomerular filtration rate of 30% or more to a value of less than 60 milliliters per minute, blah, 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 occurred more frequently in the intensive treatment group than in the standard treatment group, 1.21% per year versus 0.35% per year. Among all participants, acute kidney injury or acute renal failure occurred more frequently in the intensive treatment group than in the standard treatment group. The differences in adverse renal outcomes may be related to a reversible intrarenal hemodynamic effect of the greater reduction in blood pressure and greater use of diuretics, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers in the intensive treatment group. With the currently available data, there is no evidence of substantial permanent kidney injury associated with the lower systolic blood pressure goal. However, the possibility of a long-term adverse renal outcome cannot be excluded. These observations and hypotheses need to be explored further in analyses that incorporate more clinical outcomes and longer follow-up, end quote. So it appears based off that quote that the authors do believe that there were some interactions with the medications that led to these increases in adverse outcomes. And when I was reading this, as a little bonus for you, I was reading an article from You and Your Hormones, an education resource from the Society of for Endocrinology. I'll leave a link below, and it was explaining how aldosterone in particular interacts with or impacts your blood pressure. And it had this really nice figure that I'll throw up on the screen now, just so I can maybe break down a little bit about angiotensin converting enzyme inhibitors. Pretty much, you may be familiar with angiotensin converting or angiotensin receptors because during the they were talked about a lot during the COVID-19 pandemic because at least at first I didn't really follow along with it enough probably to say if it's still the case, the spike protein on the coronavirus would bind to ACE2 receptors to get into cells. Anyways, the reason the ACE2 pathway is important is that your kidneys will kind of sense your blood pressure. And if your blood pressure is too low, they'll release a hormone called renin, which will interact with an inactive protein called angiotensinogen. This type of protein is called a zymogen. These are inactive proteins that once cleaved or pretty much interacted with can become active. Renin activates angiotensinogen, turning it to angiotensin 1. And then an enzyme, angiotensin converting enzyme, will turn angiotensin 1 to angiotensin 2, which will cause increases in blood pressure in its own right by causing vasoconstriction or causing the blood vessels to constrict, and also by acting on the adrenal glands to cause them to secrete aldosterone, which causes salt retention. So it causes your kidneys to hold on to more salt and filter less salt out of the blood into your urine. And I believe it also causes your kidneys to excrete more potassium. But anyways, this pathway is kind of an evolutionary response or a responsive mechanism for increasing blood pressure. And so ACE inhibitors or angiotensin converting enzyme inhibitors will block that angiotensin converting enzyme to decrease the amount of angiotensin 2 in the blood. And angiotensin receptor blockers act in a similar fashion in that they decrease the impact of angiotensin 2 to increase your blood pressure, thereby lowering your blood pressure. And so this, along with diuretics, which, like I said, cause you to excrete more water in your urine to decrease the volume of your blood, will impact the flow coming into the kidneys and may also just impact the kidneys directly, at least is the hypothesis of the authors. And this may be the reason that we're seeing increased kidney issues in the intensive treatment group. Particularly because they're using more of these drugs. Again, the distribution of the medications used was fairly similar. It's just they were using more, as the name intensive treatment group implies. Now, moving into the discussion, the authors kind of break down how the results of this study, the reduction in risk of additional dropping of blood pressure below kind of the standard of getting below 140 millimeters of mercury, contributes to the overarching body of evidence. Quote, the results of SPRINT add substantially to the evidence of benefits of lowering systolic blood pressure, especially in older patients with hypertension. Trials such as the systolic hypertension in the elderly program trial, the systolic hypertension in Europe trial, and the hypertension in the very elderly trial showed the benefits of lowering systolic blood pressure below 150 millimeters mercury. However, trials evaluating systolic blood pressure levels lower than those studied in these trials have been either underpowered or performed without specific systolic blood pressure targets, end quote. Moving a little further on, quote, comparisons between SPRINT and the ACCORD trial are inevitable because the trials examined identical systolic blood pressure targets, less than 120 millimeters per mercury versus less than 140 millimeters mercury. In contrast to the findings of SPRINT, the cardiovascular and mortality benefits observed in the ACCORD trial were not statistically significant and were of a lesser magnitude. Several important differences between these trials should be noted. The ACCORD trial enrolled participants with diabetes exclusively, whereas SPRINT excluded participants with diabetes. In addition, the sample size of the ACCORD trial was only half that of SPRINT, 4,733 subjects versus 9,361. SPRINT enrolled an older cohort, mean age 68 versus mean age 62, with 28% of participants 75 years of age or older, and also included participants with chronic kidney disease. The ACCORD trial showed a non-significant 12% lower risk of its primary composite cardiovascular outcome with a 95% confidence interval that included the possibility of a 27% lower risk, which is consistent with the cardiovascular benefit observed in SPRINT. The ACCORD trial also used a factorial design that included comparisons of standard and intensive glycemic and lipid treatment targets in the same trial. A secondary analysis of the ACCORD results showed that as compared with the combined standard glycemia and blood pressure treatments, intensive blood pressure treatment alone reduced major cardiovascular outcomes by 26% without additional benefit from combining the two intensive treatments. Thus, the difference in results between the trials could be due to differences in study design, treatment interactions, or the play of chance. An inherent difference in the cardiovascular benefits of systolic blood pressure lowering between the populations with diabetes and the population without diabetes seems unlikely but cannot be ruled out, end quote. So I just wanted to include that, although I know it was a bit lengthy, one, to address that, when I'm breaking down these individual studies, it is still important to consider them in the context of the consensus of all data kind of on blood pressure in this case, not just to cherry pick and look at one study and use it indefinitely. And so when we do that, in this case, we see there were differences in the ACCORD trial, which looked at had similar targets for blood pressure. But as the authors of the SPRINT trial note, there are considerable differences between the two, such as sample size and that they had different inclusion criteria. The ACCORD trial included individuals with diabetes, but didn't include individuals with kidney disease, whereas that was the ACCORD trial. The SPRINT trial did the opposite. And also, individuals in the ACCORD trial were also part of the intervention involved medications for blood sugar and for lipid management, so like cholesterol lowering medications. So all these taken into account, these differences may explain why there were significant results in the SPRINT trial, but not in the ACCORD trial. The other reason I bring it up is, in addition to ACCORD trial, it mentions the other trials in that quote, the previous trials that looked at blood blood pressure medication use and different targets for blood pressure. And it kind of brings us back to what we were talking about at the very beginning, in that the reason that the sprint trial is important is that it was kind of a pivotal moment in hindsight, um, for the gauging what the appropriate or maybe optimal targets for blood pressure lowering would be to reduce cardiovascular disease events. And yeah, that's why this study is meaningful. And really, the main reason I decided to share it is that it does show, to a degree, in the context of potentially adverse events, which I'll talk about in just a second again, that lowering even further than just below 140 does have an advantage for uh, reducing risk of cardiovascular disease. Moving on to talk about some of those adverse events, the authors do acknowledge them and discuss a trade off that I kind of alluded to earlier on. Quote, in Sprint, significant between group differences were noted in some adverse effects that were attributed to the intervention. Orthostatic hypotension was assessed during a clinic visit. As assessed during clinic visit, was observed less frequently in the intensive treatment group than in the standard treatment group, but syncope was more common among participants in the intensive treatment group than among those in the standard treatment group, 3.5% versus 2.4%. As was hypotension, 3.4% versus 2%. There was no between group differences in injurious falls. There was a higher rate of acute kidney injury or acute renal failure in the intensive treatment group, as noted above. These adverse events need to be weighed against the benefits with respect to cardiovascular events and death that are associated with intensive control of systolic blood pressure, end quote. So, as they mention, there is a trade-off. As we saw in these results, there is an increase in adverse events, or there was an increase in adverse events in these subjects, and it's important to weigh those adverse events against the risk or the differences in risk of cardiovascular disease and death, and the different events that made up the composite outcome. Continuing on, the authors kind of address some practical considerations of the feasibility of lowering blood pressure the way that they did in this trial. Quote, the Sprint results raise important practical issues. Hypertension control to a blood pressure of less than 140 over 90 millimeters mercury is achieved in only about 50% of the general population of the United States, which suggests that control to even that level is challenging. We excluded patients with more severe hypertension, and control of systolic blood pressure to less than 120 millimeters mercury required, on average, one additional antihypertensive drug. In addition, the median systolic blood pressure in the intensive treatment group was just above 120 millimeters mercury, which indicates that more than half the participants had a systolic blood pressure above the 120 millimeters mercury target. These observations suggest that achieving a systolic blood pressure goal of less than 120 millimeters of mercury in the overall population of patients with hypertension would be more demanding and time consuming for both providers and patients than achieving a goal of 140 millimeters mercury, and would necessitate increased medication costs and clinic visits, end quote. So they kind of address there that even though there were improved outcomes, this may not necessarily be as simple as the study kind of suggests, in that it's very difficult in real life settings to get individuals to lower their blood pressure enough to reach these levels via just medications. They go on, last quote here, just their kind of conclusion and takeaways from the study. Quote, in conclusion, targeting a systolic blood pressure of less than 120 millimeters of mercury as compared with less than 140 millimeters of mercury in patients at high risk for cardiovascular events, but without diabetes, resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause. However, some adverse events occurred significantly more frequently with the lower target, end quote. So I kind of already addressed my big takeaway, or, the importance of this paper is that atherosclerotic cardiovascular disease is the leading cause of death globally. Hypertension, or increased blood pressure, is an important risk factor for that. And there was disagreement up until this study, and maybe even continuing afterwards, what the optimal or kind of ideal target blood pressure we should be shooting for to substantially or sufficiently reduce risk associated with increased blood pressure and cardiovascular disease. I think even though the absolute risk reductions were small in this study, like we talked about, it's notable that this was only over 3.2 years, albeit in a population that had an increased risk. And also, if we look at the numbers needed to treat, it was 61 for preventing an event. So to me, that's fairly significant, uh, on its own. And going to the time scale or kind of timeline perspective, I think although this was a lot of older subjects, and it's not necessarily directly applicable to younger individuals, if we consider that elevated blood pressure, kind of the risk of elevated blood pressure accumulates over many years of that increased blood pressure enacting or creating damage to the endothelium, the blood vessels, then uh, this may be interpreted as support, again, not direct kind of evidence for, since it wasn't in this population, but support that younger individuals should be shooting for below 120 millimeters of mercury, and that they shouldn't just be okay with their blood pressure being, above 120 systolic or above 130. Because if you really want to prevent or decrease your risk of cardiovascular disease, this is an important risk factor. And based on the outcomes in this paper, it appears that lower, specifically lower than 120, is better for reducing your risk. And I think that wraps up all I really have to say about this. Insert Forrest Gump meme. Yeah, I wish that you found this useful. And if you want to keep getting more health and fitness content like this, you can check out the rest of my YouTube channel. I have some more kind of short form and long form content there. And then also pretty much everything I do, I post on Shortcut U, my blog on Substack, and you'll see a lot more research-based content. Definitely a lot better groomed than what I'm posting here. I know I kind of mumble and go off on tangents and mispronounce or misread things when I'm reading off the quotes, but I still enjoy this kind of medium for sharing some of the cool stuff I find. But if you're looking for something that's a little bit more well organized, you can go check out a lot of the deep dives or even just shorter posts that I write on Shortcut U. And with that, I will catch you next time, where we'll talk about a follow-on study from Sprint that has additional kind of important implications, especially practical implications when it comes to the importance of paying attention to detail when measuring your blood pressure to get an accurate reading. Anyways, thanks for listening, and I'll catch you next time.